This is actually what we're talking about in European reference networks, which is an exciting concept also, or especially for us as patients with rare diseases and rare cancers, because quite often there have been networks which have been funded for quite a time with European funding, but they were often not sustainable, they were often not funded in the long run, they were often not establishing a structure how research could be done in these kind of diseases. The way they have been set up was in the context of a new law that was set up by the European Commission, the Parliament, which was strengthening the rights of patients for cross-border healthcare. So to really give patients the rights to access health in other member states than they live. And in the context of that law framework was established to strengthen cooperation in complex diseases, in rare diseases, to pool the knowledge and to try to establish cooperation also in research. It's a new directive that is now transposed into law in the different member states, which means the member states in the European Union need to put their own laws in place for that, which will take a while, but in 2000 it's really becoming reality now, because in 2015 the call for proposals will go out. And this doesn't mean there will be a specific network for each of the rare diseases, the rare cancers, because this is not possible. There are more than 5,000 rare diseases, more than or almost 200 rare cancers. But there will be, let's say, they will pool different diseases in these kind of networks, and I think it's a very important thing for us patients. In 2016, we hope we have the first reference networks. The challenge will always be sustainability, funding, who will pay the bills, who will actually support these kind of research networks in establishing those. But I think it's an exciting opportunity which we want to discuss now.
ESMO is very proud to be part of an initiative called Rare Cancers Europe. We had a pathological consensus meeting with the pathologists and the medical oncologists in February, and we also presented our case to the European Commission at an event at the European Parliament, because we recognize that diagnosis is the most important part of the cancer patient journey, because if you're not diagnosed correctly, then you're also not treated correctly. And that's especially true for rare cancer patients. So what we wanted to do is we wanted to raise awareness about the issue with the politicians, with the public, and we'll continue to do so. We'd like to establish criteria for these European reference networks that are specific to rare cancers, and one of them is the pathological diagnosis. And since there are so few cancer patients maybe in different countries, we're really pushing for these European reference networks so that once a patient is correctly diagnosed, then they have a reference center to go to, either for a second opinion for the diagnosis or for the treatment. Thank you.
And sometimes duplication is needed. You need to duplicate research to validate it. That's something else. But sometimes in basic research, they are doing the same thing at several places, and this is not helping us advance. And I think that even if you then go to the rare cancers, some of the projects are basic. Basic tumor biology is no different for a sarcoma than from another cancer, immunology. So it will be really a challenge for the future to optimize the use of our scarce means in research, to get the best out of the researchers and to focus them on the big problems.
Or does anybody in the room have any thoughts on how this will facilitate second opinions on pathology, to have the network set up to facilitate better analyses of tissue in rare cancers?
I think a lot of issues with these reference networks are still unclear. There's a lot of discussions, a lot of questions going on, and we are looking for more answers. But this was also one of the questions. In the moment, this reference pathology is very much done by experts with a high level of passion for a specific disease. So they take this on beside their normal work and do this to get a second opinion. Specifically in sarcomas, we see this. There are not so many real experts in pathology who are really able to diagnose a sarcoma in a very first setting. We still have 25% of wrong diagnosis in a first setting. So these are part of the questions, but also questions for these reference networks is about the funding. It's about the structure, how these structures are set up. The question is this only maybe one specific center per country who is something like a contact point for the country, or are there more centers in the country linked to these are a lot of open questions, and I think that has very much to do with the call that's coming out next year. So how is the call defined, and also with the proposals that are set to this call. I think a lot of questions, a lot of open issues, a lot of speculations are going around in the moment. So we are looking for answers and we are looking for solutions. And I think it's very much based on the individual community. We just have had a discussion in the sarcoma community that we really need to sit together with the medical experts, with the patient community to come up with a solution, to come up with a recommendation or with a proposal to this.
Kati, your question regarding the pathology reference work, which is of extremely importance, do you aware of somebody aware of such a European system, or is it? But it's not part of this call, as I couldn't think, because it's another issue. It's a question of money and resources and also quality. I'm working in see patients in several parts of the world, very often many also in Russia. It's extremely poor histology. Diseases are completely wrong very often, not only there but also in Germany. But there's no network even in Germany existing, only for lymphoma and for sarcoma, some way, a little bit, but not standard. Normal patient cannot get reference pathology, only if it's in trials or at a center and so on. So it's very, very poor, but it's a key, the cornerstone of diagnosis and treatment, and beginning of the quality of management of a patient. So even there are many, many deficits, and it would be great if this could be solved on an international, at least European way.
Because this discussion raises another point. This is the multidisciplinary work in cancer in which the lab is also a partner, which is very often forgotten. It is the pathologist. He is a man from the lab. He's sitting behind his microscope, and very often they consider their work as an art rather than a science. Although today, even at European level, we are striving to get the labs accredited. Even the pathology labs, they have to follow procedures and they have to follow guidelines for their work. And I hope that in the near future, this will improve the quality of their work. But of course, if your country is not following this, if in Belgium, pathology labs have to be accredited, that's new. Otherwise, they cannot continue to work. And I hope that this will be visible for the clinicians, that the quality of the reports they make on tissue research will be better.
Thanks, Eric. But I mean, should we as advocates also be encouraging pathologists to come face-to-face with patients, perhaps actually even giving them the diagnosis?
It's a very difficult thing, because the pathologist is one of the specialists who are hidden behind the wall, like the radiologist, the lab pathologist, you never see them. What should be done is that they should commend their work, and the doctor who is prescribing, because he only works if he got a prescription of the treating clinician, he should discuss what the pathologist did. Because why are some doctors pathologists? You know? Do you have to answer that? Because they are shy and they hate contact with patients. You shouldn't force someone who doesn't want to speak to patients to do that. That's true. That's not an invention of mine.
Well, actually, I was recently at the European Society of Pathology, and I think they're ready to come out from behind those offices in the basements and the offices behind the walls. And the ones I've spoken to seem to be quite keen to meet the patients. I mean, it's a big sea change for them, and they may need some extra help in communication skills, not being used to working so closely with patients. But I think the other thing that pathologists could do is encourage patients to make sure that their tissue is donated for research when they have their resections and their surgeries, because there is a shortage of good quality tissue from rare cancer patients, and not all patients who are going into surgery realize that, and not all of them will sign the consent forms. So I think we have a lot of work perhaps to do to encourage pathologists to interact more.
Yes, and if patients would speak with them, they will be motivated to work better, because they never see the face behind the tissue. They only see the biopsy. They don't see the patient, his family, and what will happen if they make an error.
Unfortunately, I have to agree with you, because it's true. We often are hidden at the microscope, but I want to take at home your suggestions, because I think it's really important to connect with other specialists and with the patients. I'm here with an association, and we have to work all together to improve all of our works in connection with the works of oncologists, of radiologists. So this is what we will do when we will be at home, working all together to improve the treatment of patients. So that's it.
Thank you very much. That's great.
Thanks for being here.